Okay, so today we're going to talk about progressive anesthesia, and I've talked about this in some other videos, but we're going to kind of go into a little bit more detail on how it actually works. So some of the precursors to actually getting into the patient's mouth is what type of anesthesia we're going to be using. So the two types of anesthesia that I only use and what I've used throughout my entire career are first lidocaine, 2% with epi. And that's what's going to be used for 95% of all of your dentistry. The nice thing about lidocaine 2% is that it is FDA pregnancy category B. So that's one of the things that you're going to use. Now, there are a lot of doctors who like to use an articaine or a septicaine, thinking that the chemistry behind that anesthetic is going to help people get numb. The issue with that is, first of all, I haven't seen it in my career, being that chemistry is more important than anatomy. Anatomy is definitely more important than the chemistry, and I've been able to do all of the dentistry, including wisdom teeth extraction, all root canals, all of that with lidocaine. So if you see that you're grabbing your articaine or your septicaine, understand that it probably isn't necessary. The other problem that I have with articaine or septicaine is the issue with the paresthesia around the inferior alveolar nerve. And although it's not been proven, and yes, they use septicaine in Europe quite a bit, again, one less thing that I want to worry about is any issues with paresthesia around the IAN. The bigger issue that I have with septicaine and articaine is the FDA pregnancy category C of septicaine and articaine. And my worry is when I see doctors start to use septicaine or articaine a lot, I always wonder, do they know the pregnancy status of their patients? And not all of the patients know their own pregnancy status. And so it would be just devastating to me as a clinician if one of my patients came in and their child had a cleft palate or something other that happened during pregnancy, and then that mother would be thinking back to whatever ingestion or any medicine she had during her pregnancy, or if it was her fault. And so that's why I have largely avoided septicaine or articaine in my practice, okay? The other thing is making sure that I only use the 30 gauge needle. The 30 gauge needle, if you think about it, I used to use the 27 gauge needle, which was also a little bit thicker and longer. And you just have to understand, if you're going at a younger patient, okay, and they see that longer needle, obviously they're going to be more scared of a longer needle and a thicker needle versus a shorter needle and a thinner needle. So if you have, and this is the decision that you make a lot of time in all of your clinical dentistry, is if you have the option of two things and one of them is better, why don't you just use that? And so I actually learned the 30 gauge needle from my oral surgeon in dental school, and that was all that he used. And sometimes people are like, oh, it's kind of a small wimpy needle. But if you think about it from the patient side, it's a lot more comfortable for them to see that coming at them, especially for younger kids. Now, the problem that some dentists have is they think that they are going to hub out when they go onto the IAN. But if we'll take a look at it when I do go into the IAN and I sound on bone, I will be at least a centimeter away from hubbing out, and I've never even gotten close to hubbing out. The other thing too is bending the needle is super important ergonomically and getting the anatomy perfect. So you'll see how I bend the needle, and that makes a huge amount of difference. The other last thing here before we get started is making sure that you're using this needle holder. It's super important as far as your exposure incidences, that you definitely want to be using a needle holder to prevent your assistance from having an exposure incident, okay? So you'll just place that like that every single time, okay? One other thing that is super important is I never have the assistants load my anesthetic because they have the potential of bending the hub. And so what I'll do is I will have them, they're okay to place the needle in here, but the doctor is the one who always places the anesthetic, okay? Okay, so another tip here is every once in a while when you have your stopper here that is, or your plunger that's a little bit stuck here, a lot of times I'll see doctors that are trying to fiddle around with this, and they'll try to hold this with their thumb and then pull back, and then it'll rip your thumb, okay? Or rip your glove on your thumb. The easiest way to do that is to just simply hold it down and then twist your syringe, and then that'll come right out, okay? So again, another tip to not rip your glove is that, okay? One of the important things here is to know how to bend your needle, okay? Bending your needle has been one of the things that have made it super simple for me to be able to give anesthesia in the right spot, okay? So when I take off my, my cap, okay, I don't want to bend it at the hub. So what I'm going to do is I'm going to use my thumb and then I'm going to use my finger to bend it at just a little bit past the hub. And you're going to see that maybe that's a 30-degree angle, okay? Now again, I'm never going to cap my needle using two hands. I'm going to always use the scoop technique, and then I'm going to put it back on, and then I'm going to place it here. So every single time, I hate seeing doctors. In fact, we did have a doctor who had an exposure incident with an AIDS patient just because of that little situation right there. So always use the scoop technique to cap your needle, okay? So now that our needle is bent, okay, I'm going to show you the reason why I like the bent needle. Okay, so the first thing is, if I did not have a bent needle, okay, do you see that I would have to pull the lip back down here to be able to get to the right angle at the inferior alveolar nerve? But because I have the bent needle, I'm able to ergonomically go straight at the IN without even touching the opposite side of the lip, okay? Now, another thing that I always see doctors doing is what we learned in dental school is to put your finger on the ramus and then pull back in order to see the raphe, okay? The issue there is if you see the tip of my needle compared to the tip of my finger, I'm only a centimeter away. So I do not ever put my finger on the ramus. I will simply just take my finger and pull the lip out just like this, so that when I'm giving the IN, do you see that I'm about 4 to 5 centimeters away from the tip of that needle? So the tip of my needle is never close to the tip of my finger because I want to avoid that exposure incident, okay? Now, when I'm doing the IN, okay, I'm literally going to place, if you see here, I'm going to go under the mucosa, and I'm going to give literally a drop, okay? Now, some doctors, they think that I'm saying a drop and they think that I'm giving a quarter of a carpule, but I'm literally giving a drop and I'm not sounding on bone on that first one. If I'm gonna get this quadrant numb, this is exactly how I'm gonna do that. You saw my first injection was 1 drop underneath the mucosa, and then I'm literally gonna come in for my second drop right under the mucosa. And the patient, I'm watching the patient's eyebrows. If they go up, that means that they can start to feel it, and I'm gonna pull out immediately. If you take a look at my anesthetic, I've now given about 1/8 of a carpule, okay? Between the first drop and then the second one, I gave just a tiny little bit more, okay? And I still haven't sounded on bone. Okay, so now I'm gonna go in for my third round here, and now this is the first time that I'm going to sound on bone. So you're gonna see I'm gonna go in very lightly, sound on bone. Now, do you see that I'm sounding on bone and I'm 2 centimeters away from hubbing out? And now I'm gonna place, this is the first time that I'm there, so I'm gonna place just a little bit more. So you can see I've now gone about 1/4 of a carpule, but I've injected 3 times. So now I'm always gonna start with the IAN, make sure the IAN is numb, and now I'm gonna go for the long buccal. With the long buccal, I'm not gonna give 1/4 of a carpule. I'm gonna give just 1 drop on the long buccal, okay? So now that the IAN has started to get numb and the long buccal started to get numb, now let's say I'm doing an SRP, let's say that I'm doing a root canal, I'm gonna always do it the same way. So again, now I'm gonna start going on the vestibule. So you're gonna see, I'm gonna pull the cheek out and I'm gonna come and go down on the vestibule. Again, I'm going just a drop, okay? And I will walk it forward on the vestibule, 1 drop, okay? Now that the IAN is numb in the back, I'm always going from the root of the nerve all the way to the front, okay? And then I'll warn the patient that these ones up here can be a little bit more sensitive, and that's it, okay? So now I've gotten all of this started to get numb, and if you look, I've only used 1/2 a carpule, okay? But now that the mucosa is starting to get numb, he's not gonna feel the rest of the pinches. So now it's important that I get, let's say that I'm doing an SRP, I'm gonna get the papilla numb, okay? So now that I've gotten the IAN numb, the long buccal, I might give him a little bit more on the IAN, and then I'm gonna come in and get the papilla numb on every single papilla. That way I can go and be more aggressive when I'm doing my SRP, okay? So I'm just gonna let that blanch, and I'm gonna go after every single papilla, okay? Now, if the patient still is not numb, okay, and I'm usually gonna give about a carpule or 2, okay, usually 2, I do have the option of getting them numb on the lingual. Okay, so if I did need to get them numb on the lingual, again, I'm gonna take my mirror, okay, and then I'm gonna slide it kind of by the side there, and I'm gonna be able to go in and get them numb on the lingual, okay? Okay, and a lot of times I'm having to walk the anesthesia around 360 degrees if they're not getting numb, okay? But you can see that that's a very safe way, and I don't have to shake the lip, I don't have to use any topical. Why don't I use topical? Because 50% of people like it, 50% of people don't like it, plus you make a big mess on your tray and the assistants have to clean it up, and you have an additional expense. I don't shake the lip because I've had some patients also, less patients than topical, that have complained about the shaking of the lip. So I just use that progressive anesthetic technique, and I've had a lot of people that really, really like that more than any other of the other placebo effects or gizmos that people try to use to get them completely numb. Now, if I were doing a root canal and I needed to do an interpulpal, what I'm gonna do with my needle is I'm gonna make a second bend in my needle, okay? So you're gonna see that it looks kind of like this. That way, if I'm going into number 19 and I'm doing an interpulpal, I can go right at it and then go ahead and get them numb, okay? So one of the big things is using the mirror, okay? So if we look at positioning here on this, let me show you all of the positions that I'm gonna use, okay? On the maxilla, I am not gonna really hold the lip out like this. I am gonna use the mirror to come up here and get things numb here. The same thing here with the anterior. I don't wanna get my finger close to the tip there, so I am just going to use my mirror, okay? The same thing here. These are the positions I'm gonna use for all of my maxillary anesthesia, okay? If I'm gonna go onto the lingual, I'm gonna always use this finger rest here. So go ahead and open up, and then I will place my anesthesia there. Now, I never give anesthesia on the palatal unless the patient asks. Yes, I do all of my root canals without getting the palatal numb. I do all of my maxillary extractions without getting the palatal numb, unless the patient asks for it. Meaning, I start luxating the tooth and the patient's like, ooh, I can feel it. I'm like, where do you feel it? On the cheek side or the tongue side? And if they say the tongue side, then I say, well, I'm gonna go ahead and get you numb. And then usually I'm like, these are gonna be stupid. They are terrible on the inside. And then I give it to the patient, and I usually am going to do this. I'm gonna start up here next to the lingual margin, and then I will walk it down. I'll blanch it, and then I'll just follow the blanch until I feel like I've gotten enough. After that, the patient is the one who requested the anesthesia, so they aren't super upset. I've seen so many patients that are like, hey, you're not gonna give me numb on the tongue side, right? And I always tell them, I don't give it to you unless you ask for it. And if you give anesthesia to patients on the palatal without them asking for it, I can guarantee you that they're gonna not come back to you, because there's so many patients that come to me and say that they didn't like their last dentist because they gave him palatal anesthesia without them knowing. So again, that's kind of the positioning on a lot of that palatal anesthesia, okay? And do you see how I'm gonna use my finger rest there, okay? If I'm giving palatal over here, that's how I'm gonna do it, okay? If I'm giving lingual here, I'm gonna do it that way. You can see here that I have not been within 4 to 5 centimeters of the tip of my finger, okay? So if I'm gonna do the IAN over here, open big, okay? I'm gonna come in here, and I'm just gonna pull that lip, and if I need to, I can pull it forward, and then again, I'm just going straight at the raphe, and then going in and getting through the mucosa, and then sounding on bone, okay? When I'm coming here to the vestibule, do you see that I use my finger as a rest so that I have complete control where that needle tip is compared to the tip of my finger, okay? And that's gonna be my anesthesia there, okay? When I come here, that's how I'm gonna do my anesthesia there, okay? And that's how I'm gonna do my anesthesia up there. So you can see how much I use this mirror so that I'm not close to the tip of my needle, okay? And then again, every single time, it's gonna be back onto the needle holder and using the scoop technique. So in summary, things on progressive anesthesia. Your first thing is to make sure that you're using lidocaine or prilocaine. Always use the needle holder. Always use the 30 gauge needle. Your first anesthesia application that you're going to give is always going to be at least or at most 1 to 2 drops. Then go for just a little bit more, looking at their eyebrows. If their eyebrows go up, you stop immediately, okay? You're always going to start at the, you're always going to bend your needle so that you can have better ergonomics, okay? And then you're always going to start at the root of the nerve and then work your way to the extension of the nerve, okay? You're always going to get them profoundly numb. One of the things is getting them, is using progressive anesthesia, but getting them profoundly numb. So usually for a filling, I'm gonna use maybe a carpule or 2. For a root canal, I'm usually gonna use 3. For an extraction, usually 3. I'm gonna keep the tip of the needle very far away from the tip of my finger. And then you're definitely gonna make sure that you do not give any palatal anesthesia until, unless the patient asks for it, but usually you're not gonna need to do that. But that's pretty much everything that you're gonna need to know for progressive anesthesia and for all of the positioning.